Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist here at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good day to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
Well, we have three great questions for you today, Dr. Mingle, so let's just jump right in.
Bring them on, Kyle.
Our first question for you today is from Julie, and Julie asks, on MIPS measures 5 and 8, can we use code 3022F to indicate when a patient's LVEF is greater than 40% and the patient does not meet the denominator qualifications for these measures? Or would we leave these unanswered?
Well, great question, Julie. Of course, for all those who can't rattle off those numbers off the top of their heads, MIPS measures 5 and 8 regard left ventricular ejection dysfunction or left ventricular dysfunction and depressed ejection fractions. Julie, for those two measures, we want some way to exclude patients with only mild left ventricular dysfunction. The ICD-10 diagnoses for left ventricular systolic dysfunction, LVSD, or heart failure, are not adequately specific. They really encompass all levels, mild, moderate, and severe. Medicare is asking you to report only on those with moderate or severe LVSD, and you must exclude those. Well, might not be an adequate, the right word. It's beneficial to exclude those with only mild LVSD. I can't imagine Medicare downgrading your submission for including mild LVSD, but it would actually hurt you in your scoring if you miss the interventions in someone with mild LVSD. It's irrelevant to the reporting. So if you include them in your denominator, you'll get a lower than deserved score. And none of the ICD-10 codes, reflect mild, differentiate between the severities. And of course, they've also got a numerical level to it, looking for LVEF, that's left ventricular ejection fraction, being less than 40 is moderate, and those above 40 are mild. Now, so you can accomplish that differentiation either by delivering a number, the actual measured left ventricular ejection fraction, or if you grade it as mild, moderate, severe, give us that grade, or whoever's doing your reporting for you, deliver that grade, and in the logic, we can exclude the milds in any way. But there has to be a way of delivering that. And it isn't just the code you put on your billing form, because none of them are specific enough to mild, moderate, or severe left ventricular dysfunction. Now, an adequate way to do it is with the code 3022F. Now, that's called a QDC code, or a quality data code. Medicare publishes QDC codes on the specifications for every measure to cover either the performance met, not met, or an exception, or even the sub levels within that. And 3022F is such a code that indicates that the patient does in fact have left ventricular ejection fraction problems, or left ventricular systolic dysfunction, but it's only mild. Or the other measure actually uses the codes M1150 or G8923 as to indicate that it's moderate or severe dysfunction. So you can use those codes. They're not pertinent in your LCD-10 coding, and they're not typically used in the language of any reporting or anything in the EHR. But particularly if you're building a system using your claims data as part of your data collection and delivery system. Those are quite effective ways to use it. And I would recommend using Medicare's standard codes. Even though you never deliver these to Medicare, you deliver these codes to your registry, and they use them to help determine which patients should be included and which excluded from your denominators. So a lot of different ways to do it. We pride ourselves with trying to make the best of your strengths and weaknesses. So when you engage with us to do those kinds of measures, we will help decide for you what's the easiest way for you to deliver accurate data, so we can deliver for you an accurate and the best possible score that you can deserve.
And our next question for you today, Dr. Mingle, is from Rick. And Rick asks, I have a question about MIPS Measure 130, documentation of current medications in the medical record. The specs say, eligible clinician attests to documenting in the medical record they obtained, updated, or reviewed the patient's current medications, or documentation of a medical reason for not. I'm trying to determine if the documentation has listed the medications and the clinician signs the note, if that is enough of an attestation, or would we need a separate attestation statement? If our EHR has a hard stop to reconcile medications, does this hard stop count as an attestation?
Oh, great question, Rick. And I think this is important to a lot of people out there. Measure 130 is a fairly common one to submit. The answer is really in the specifications, even in that part that you quoted. The eligible clinician attests and you completed that for us. Medicare's actually looking for an attestation. And that makes sense if you're understanding the measure and the dynamics of how this data is collected and recorded. And again, getting back to the specs, Medicare is going to, if Medicare audits your records, they're going to be looking for that attestation that indicates that performance was met in the fashions that they describe, both in that sentence of the specifications you quoted, or in the preamble. Medicare, and part of the specifications, Medicare discusses the rationale and what they're expecting to see, and some of the color is in there. Now, there should always be a medication list in the electronic chart. That is, of course, unless the patient is on no medications, then there is a list that's just invisible. But now the list can be right or wrong. You can be right that they're on medications, or wrong that they're on these medications. What Medicare is asking you to do is test to see if your list is accurate or not. And they want you to do that every visit. Now, unfortunately, doing the work to test its accuracy creates no reliable tags in the EHR database. I'm always looking for tags that get developed in the course of doing the work. And there's nothing in the course of testing the accuracy of of the list that leaves tracks that we can find in a query of the EHR database. So you're really stuck with a position that you have to attest that, yes, I did this. So you'd think that maybe a prescription shows that you did it, but if you're e-prescribing, making that prescription during the visit leaves tracks that say you prescribed, you created this prescription, but it doesn't tell us that you did it in the setting of having confirmed what other medications the patient's already on. And also subtracting a med or adding a med to the list also doesn't, you may have just been giving attention to that particular medicine for the reason of the chief complaint today. It may not have been done in the context of checking the accuracy of the whole list. So I think there's no other way than to build in an attestation that a patient or that the provider can select. And I don't think I can't imagine a hard stop in the EHR that is believable, that is credible. It makes sense that you're not always going to be able to test the validity of the medication list. You may not have time, either because of everything else you have to do for that patient or other patients before or after. It might not be possible for the patient's level of consciousness or awareness of the meds they're on. So an automatic attestation or a hard stop couldn't be credible. It just demands a lie if I want to finish my work for the day. So my bias is there should only be one medication list in the chart. I don't like putting a list of the medications in separate problem lists. It just introduces duplicate work, saying it all again, or rewriting it, having the system automatically put it in from the record, and it demands that it be read. You're not really doing your job unless you look at that, and it introduces a whole set of possible errors. That list should be irrelevant the next time there's a medication change, a deletion, an addition, a swap out. So it doesn't live on. I did an informal study back when I was in practice of all the number of different lists of medications each patient had, even in my own office, and then how it rose geometrically as you stepped away from the office and into the affiliated practices. We need one. It needs to be checked regularly. Your work with a patient should be to test its validity, not to redocument it, not to relist it. And when you do that, since you're not leaving tracks on the chart, you should be saying I do, and with room for variation. And what I'd like to see is just that attestation. I checked it, or if you don't check the box, it did not, but also room for a little explanation because it is different. I checked it because the patient had a credible memory of what medications they're on. I called the pharmacy and confirmed that these were the most recent medications. Or a family member came in and validated it. Explain how you did that adds a little more credibility and and a clue for what you need to do in the future when you're ready to validate it again. So I'd say, your note, every list in the EMR or the EHR should be referenced, not repeated. I would do that with a problem list, see problem list, see family history, see allergy list, that sort of thing. Never make an extraneous copy of those lists or dictate them in. Or it can be a time saver and a quality booster if we refrained from duplicating that work. And someday I think we can be free of that requirement to say see medical record or see medication list, see allergy list. Most EHRs already have the capability of tracking your trip through the EHR. And people with the right forensic EHR skills can tell you, for this visit I spent this many seconds in the medication list, this many seconds in the immunization list, et cetera, et cetera. So I'm afraid there's no simpler way to deal with this than an attestation, and you should avoid any temptation to hard code it into your notes. It has much more credibility if the provider checks it off, and even more if the provider explains it with just a brief statement. Doesn't have to be anything lengthy. A couple words is fine if it explains what happened.
Thank you for the question, Rick. And our final question for you today, Dr. Mingle, is from Gail. And Gail asks, my team has been discussing the challenges of eCQM reporting from multiple EHRs and special concerns about deduplication. I think we understand the basics of matching and deduplication of patients. My question is the next step. Once you know that patient John Doe is on the two files and you have to get rid of one, how do you merge the data to capture the correct outcome on the eCQMs that you are reporting?
Great question, Gail. This may be fun. I've got a perverse set of fun. I apologize. It's more straightforward than it appears. It's really simply emulating at the organization level with multiple medical record systems what you'd see at the practice level with one medical record. It's a common occurrence that patients have multiple visits, multiple episodes, multiple measurements, multiple doctors, multiple practices, multiple opportunities to provide the indicated intervention. Well, we run into the same issue at different degrees of complexity with one provider with his or her one panel of patients in one EHR, but with multiple visits, or a group practice with multiple providers, patients seeing anyone there, one EHR, multiple visits, or when we step into the next level of organization into an ACO or a community healthcare system with multiple EHRs. And of course, we run into that need to report more often across an ACO than across just a garden variety community healthcare system. The starting point for any quality measurement project is to get a complete accounting of the patients and capture the data that generally indicates measure eligibility. For us, this is usually a complete set of insurance claims for the time period. It can come from the EHR, it can come from the practice management system. It's usually in both, and those systems are often combined anyway. The next hurdle is to get all of the relevant clinical data that indicates performance. Each piece of clinical data needs to include adequate patient identifiers to match it back to the eligible patients and a date stamp indicating when it was done. Notice I didn't mention that it needs to be tracked back to the practice or the provider. That's usually in it, and it's certainly not worthless data, but we don't care where it was generated if we have the data. The data itself and when it was generated give us all the information we typically need to decide which to use. Once we have all that relevant data normalized into a single data set, each piece tagged to the patient that pertains to when the data was done, we can then take the next step. In all cases, the measure specifications tell us which particular data element determines performance. Sometimes only the most recent data is factored into the analytics. Sometimes the best measurement from the time period gets factored in. If it occurred anywhere, anytime by anyone within the performance period, performance is met. So different ways this factors in, but once you have the data, we build the analytics on top of it to match the specifications and choose the right one. The great thing about this, and we've been experiencing this ever since Medicare introduced group practice reporting, it's now taken it to another level with ACO reporting. Every provider and practice gets performance credit when any provider and practice meets performance. There's kind of a halo effect there that everybody gets credit for the good work that collectively happens. So you should, as a community, end up getting better scores than any one of what you would as an individual practice. It means we need to have all of the data about all the potentially involved patients from all of the practice. Holes in the data, well, there's inevitably holes in the data. Holes in the data put holes in your performance measurement, that is, downgrade your performance, or both, or counts against your data completeness requirement. Now, again, missing data always means a lower score. If you don't know something's happened, then you can't get a good score for it. And now, if you actually don't know anything about the patient, that decrements your data completeness requirement. If you know you have the patient, and you have some data from some practices, but not the critical data from where the intervention occurred, then you're missing performance data. But again, it's always chosen. We want all the data, and then we choose the appropriate performance meeting data element from that set. So we never individually choose the data to include. We never discard or disregard data. When there are multiple data points, each potentially meriting a different performance score, the measure specifications always tell us which one takes precedence. Great question. Thanks.
Yeah, thank you, Gail, for the excellent question. And thank you, Rick and Julie, as well. And thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. And thanks to all of you for the great questions. I want to be helpful, and I want this to be helpful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.